Hi, everyone. My name is Sadia Zapp. I'm the Managing Director of Communications and Content here at the Breast Cancer Research Foundation. BCRF's mission is to end breast cancer, and at the heart of that mission is finding the cures necessary for all metastatic breast cancer patients. Today is Metastatic Breast Cancer Awareness Day, a day meant to highlight that stage 4 needs more. There are an estimated 200,000 people in the US living with MBC. When I started at BCRF a decade ago, that number was closer to 140,000. And while that's partially explained by an increase in MBC diagnoses, that increase is actually largely because more people are surviving with the disease. We're joined by metastatic breast cancer thrivers, Christina Thammasen and Annie Bond, alongside Dr. Lisa Ann Carey, BCRF researcher at the University of North Carolina. So we're going to get started. Christina, you've been living with MBC since 2018. Can you take us back to your diagnosis, where you were in your life then and where you are now? Oh, you're on mute if you don't mind unmuting. Yep.
Yes, absolutely. So it was at the beginning of 2018. I was working full time. My family and I were settling into our first home, and we just welcomed our third child. Everything was pretty ordinary, no complications during my pregnancy, and I delivered a healthy baby girl. But around 6 months old, when I was breastfeeding her, that's when I first noticed a small lump on my right breast. And, initially I thought, okay, I've breastfed before, so it's probably a clogged milk duct. Your body is changing. There's so many hormones going on. And I didn't think much of it in the beginning. However, that small lump that was around the size of a blueberry at that time started to ache. And I noticed a burning sensation and something just felt off in my gut. So I went to my primary care doctor who initially brushed it off. They said, "You're too young. You have no family history, you're healthy, you have no risk factors. Just go home, massage, put warm compress, do all the home remedies." And so I did that. And after a few weeks, I thought, okay, this lump is not going away and it's growing bigger. And now this blueberry is growing to the size of a nickel and then to the size of a walnut. And by the time I was diagnosed, it grew to the size of a golf ball in just a matter of months. And so for me, my life went from feeling very complete to just having the rug completely ripped under me. And for the first few years after my diagnosis, I just felt very numb. And I think that's pretty common for most of us who are diagnosed uh, out of the blue. But what really kept my hope was my oncologist reassured me that there were different types of drugs and chemotherapies on the market that would work for my specific type of breast cancer. And so I'm so happy to share that I've been living with MBC for 7.5 years now. And my most recent scans show that over 90% of the cancer in my body has completely shrunk and is no longer detectable. My side effects can be challenging, but they're manageable. And most importantly, I get to parent, I get to live my life, I get to go to trips with my friends and my family. And I just feel like I'm at a really good place.
Well, thank you so much for sharing that. I think what you point out is a number of things, which is just how it's such a common story that younger patients, when they go in and even when they present with symptoms, find themselves dismissed. There are not just anecdotes, but also just solid numbers behind the fact that 80% of younger patients under the age of 40 find their own lumps. That's very typical. But again, that story is so common of being dismissed at the doctor. I think one of the things that you highlight is just that critical need to be aware of your body no
Mhm.
matter your age, and be aware of changes to your body, as well as then making sure part of what I say when we say advocating for yourself Advocating for yourself means taking care of yourself and prioritizing your health and listening to your gut when you know that something is wrong. No one knows your body better than you do. And that's what you shared here is that you knew that something was wrong with your body and you made sure to get it checked out. Annie, you recently celebrated 10 years of surviving and thriving with NBC. Can you tell us what that milestone really meant to you, especially compared to when you first learned of your diagnosis? So, if you could talk to your newly diagnosed self, what would you tell her now?
So it's crazy, first of all. I think it still feels very surreal to have hit 10 years. Like for so long, it felt like this unachievable, far-reaching goal. And then finally, when it came, I found that like all I wanted to do the actual day of was keep myself as safe as possible because I genuinely that whole day was just like this will be it. Okay, I made it to this day, so I'm probably going to drop dead today. Like I had this really weird fear that I was going to drop dead. So once I got through that weird little speed bump, I got to go to the milestone, which is to just feel very grateful, I think is the overarching piece of that, just because you don't go through a decade of having metastatic disease without having lost somebody, unfortunately, to it along the way. And so, I've just learned how to carry that with me as I go and to not only feel shame and guilt about those things about still being here. Of course, those feelings still come up. But I think now it's like I'm so grateful for the life I have and that everyone I meet, I can honor them by how I live, by taking the lessons that I learned from them, just the way that they live their life, the things that they love in their story, and then that like becomes a piece of me everywhere I go. I always describe it as like I have a little well in my in myself that's full of grief and these people's stories and this loss, but then I put everybody in this well, and when I need it to like catch on fire and motivate me, it definitely does.
Mhm.
But if I could say anything to my newly diagnosed self, I mean, I'd probably tell her to break up with her boyfriend. That would be good advice. But other than that, in a way, I wouldn't want to tell her anything other than trust, because for me, what was the most shocking is being 26 years old and having, an acting degree. I wasn't a doctor. I was terrible at science. I thought, I don't know. I have a tumor in my in my liver, and they're telling me I'm going to die. Like I don't know anything about. I don't even know what my liver does. And so I was shocked by how often I could feel when I was in the wrong place, or I could feel like I was in the right place. And I don't know what you call it. Some people call it their intuition, but there was just something in me, like the survival instinct, that really kicked in and I think led me in a good way. And the only thing I wish I would have asked for sooner was help with my mental health, because I was so determined with my physical health. I was in such good hands at City of Hope. I had such a supportive and loving family and support system, but I was so afraid to tell anybody that I wasn't okay, or that I felt alone, or that I felt like a weird little alien freak, like walking around in the world. Like I always pictured myself as a little alien from Spice World, like just trying to walk around and blend in, like, hello. And that once I found the community and was brave enough and strong enough to finally put myself out there, I didn't even have to say a word at like the first support group I went to. Everybody was saying everything I wanted to say, but it was too scared to do. And it was just putting myself in the right space. And so I think in finding community, that has really healed the mental part. So if I could tell myself anything, like, you're doing great, you're taking care of yourself physically so well, but don't be afraid to ask for help and to find the people that you're actually comfortable asking for that help from, which is for me, usually either a therapist or my community always is like the safest and best place for me to find any sort of help or to air out a feeling that I feel like is too heavy for my family or friends, which they say it never is. But we we really need each other, or to laugh at a really silly butthole joke. That's always what that community is good for too.
Well, I think your humor carrying trauma is so hard, but doing it with humor the way that you do, I think, like shouldn't be underestimated. I think that's how I found you at first, is when I was going through my own cancer journey. I think I found you because my sister, somebody sent me something you posted, and I that's how I found you, because it was just so funny and it made me laugh during a time when I was like in the darkest place of my life. But I think that
Oh,
you offer this like sort of lightness that people don't often associate with cancer at all, right? And so it's just an example of how you can be going through something so tough, but you can still experience joy and you can still laugh, right? And laughter is okay, even when you're experiencing something as devastating as an MBC diagnosis. And I'm sure that didn't come right away. It took you time, but I think that's an insight that you offer to a lot of new patients.
I
That
will say there's no community funnier than the metastatic breast cancer community. We are hilarious. Hilarious. I'm just a public example, but my God, the
Mhm.
funniest people I've ever met.
Well, I see that in you, and I just
Thank you.
love that you can share that with others as well. So, both of you have talked about living with MBC for quite some time, and that the treatments that you're on now have allowed you to do so. And Dr. Carey, as an medical oncologist and someone who specializes in MBC research, I would love your insight, because we are clearly getting better at treating metastatic breast cancer. There was a recent Wall Street Journal article that reported an estimated 20% of metastatic cancer patients living at least 10 years or longer. And more patients, specifically breast cancer, metastatic breast cancer patients, living with the disease as a chronic illness instead of an imminently terminal one. So, what are some of the latest novel therapies that are driving that progress in breast cancer?
Oh, that's a great question. And I have to say, I love these stories. Annie, Christina, yeah, I think you guys are emblematic of frankly, one of the reasons why I went into oncology in the first place is because, you know, you, you meet these incredibly resilient, funny, engaged people, and you want to help them because this is, the human spirit is fabulous. And Annie, I think you're right. Cancer patients can be the funniest. They bring to the table an amazing viewpoint, and we all can learn. And so, this is a real story, right? This is not made up, right? There are absolutely, and breast was leading the way in terms of turning metastatic cancer. Which, remember, when I was coming out of my training, metastatic cancer patients did not live very long, including breast cancer. And the goals of therapy, have been and are still control the cancer and your quality of life, right? And so you have to meet both of those goals. The good news is that, in part because of research into the science underlying breast cancer and the understanding that breast cancer is, in fact, a number of different entities that are biologically distinct and that require different therapeutic approaches, like that's where this all started. And BCRF has been like along for the ride on breast cancer research, unraveling the biology and the drivers of breast cancer that's had great impact in the metastatic setting. And I'll give a couple of examples. The first big changes in metastatic outcomes came with anti-HER2 therapy. For those, 20% or so that are HER2 positive, we now have so many drugs that in one way or the other attack the HER2, either as a protein primarily. The drugs actually work in cancers that are HER2 negative that only have a little bit of HER2, the more recent versions of them. But that was the first big jump in survival, was in that. And the second big jump has been in the hormone receptor positive HER2 negative, which is in fact the majority of metastatic breast cancer patients, where we have much better anti-estrogen therapies, which tend to be better tolerated than chemotherapy, much better helper drugs that we give with the anti-estrogen therapies to help prevent the development of resistance to those drugs. And like that's been a huge change and a huge change in outcomes. And then the third group is triple negative. And we've had some really nice advances there with the addition of immunotherapy, getting smarter about the ways we give chemotherapy and some of the newer targeted drugs. That one's a little bit behind, but has a lot of really cool things happening.
And I think you just pointed out the fact that we are not looking for a cure, right? We are looking for cures, plural, for all of the different types of breast cancer that exist. I think that's another common misconception is this idea that breast cancer truly is just an umbrella term to refer to a multiplicity of diseases. And one of the things you just talked about is HER2 positive disease versus hormone receptor positive disease and triple negative disease. For example, all of these different patient populations need cures specific to their subtype of disease. And I think that's one of the things that is really fascinating is that in our lingo, the way that we talk about breast cancer and finding a cure is a little bit of a misnomer because truly we're looking for cures for patients, right?
Yeah, although, to be honest, we don't really talk about cures in the metastatic setting. That's why the conceptual framework is really more like a chronic disease. Now that may change in the future. There's some exciting things that are happening that could, change that. But frankly, at the moment, I do think a chronic disease, much like high blood pressure or diabetes or things like that, are managed and managed well with a minimum of side effects from the drugs that you're giving, and people can live for a very long time.
Right. I think that those are the nuances, right, of what we're talking about when at large people are talking about breast cancer and the way that we're hoping to end the disease. But part of that means taking away the life-threatening potential of an MBC diagnosis and instead it becoming, even if for the time being, what we're searching for is let's take away its ability to take lives and instead make it a managed disease. While the long-term hope and goal is let's cure the disease so that no one has to live with it and doesn't have to be on drugs, right? So there is that sort of step-by-step approach that we're thinking of how are we actually going to solve this riddle of metastatic breast cancer. So I will say that at one of our last year at our BCRF symposium, where we gather all of our researchers, we're doing that again on October 30th. One of our scientists, Dr. Ian Kropp, had said something that I was so happy to hear as a breast cancer patient, where he says, I do consider some of my patients cured. He said, there are some MBC patients that I have today that I think are for all intents and purposes cured. And that was such a hopeful statement to hear from him that the treatments have gotten so good. And you just mentioned one for her too, where now there was a treatment that was so successful that we've been able to classify entirely new groups of patients as having HER2 low or HER2 ultra low when they normally would have been considered HER2 negative. So I will say that the advances we're making are even beyond things we may have originally expected to be making, right? So, Christina and Annie, you both represent another trend, which is the growing incidence of breast cancer in younger women. So, younger women, especially, are at risk and about 40% more likely to be diagnosed with metastatic disease than women over the age of 50. And another study, though, recently showed that younger patients now, thanks to all of these new drugs, are 80% more likely to survive the disease in the past decade than they were previously. So we're getting better at treating breast cancer in younger women, but they're still at high risk because we are more likely to have aggressive disease and be diagnosed at later stages, which we all experienced here as well. So Christina, can you share what it's like being a mom of young children while living with MBC and what advice you'd offer patients with little ones?
Sure, absolutely. Well, in all honesty, it's very much like being a mom without MVC. It's jam-packed with schedules. I still do the morning drop-offs, the pickups, the soccer games, tucking them in bed, watching them throw a temper tantrum, all the things, the ups and downs of parenting, but I'm doing it in spite of my metastatic disease. And I want to say that because that was probably my biggest fear when I was first diagnosed was, oh my goodness, my baby was just born. Am I going to see my children in 2 years because at that time they were only giving me just a few months or a few years to live. And that's very, very scary. But I can assure you that with the drugs that I've been on, my side effects have been more manageable. And it doesn't mean that they don't get challenging because they do. I'm currently on a regimen where I come in for an infusion every 3 weeks. And so, knowing that I'm going to be sick, it just requires a lot of prep and planning. So, this means that I have to ask, just like what Annie was saying, asking for help and getting over that victim mentality of, well, I shouldn't ask for help. I don't want to burden my family. And that's something that I had to also work through over the years. But knowing that everyone does want to show up for you, but how they show up is just going to look differently. So I do all the morning drop-offs. Um, I just do it with more intention. And if anything, that has been a gift that cancer has given me is that I parent my children so much more intentionally now because they're watching me. They are watching how I live my life. They are watching how I live with my disease. And when I think about it, when my youngest was first born, all she's ever known is mommy has had cancer. And she's seen all the various stages of hair growth and weight loss, weight gain, um, times where I wasn't feeling well and I was in bed for weeks at a time. And those are just some of the harsh realities of this disease. And so I don't want to paint that it's always been an easy road because it hasn't. But I think what I've learned as a parent is our children need to see these struggles because they're human. And how we choose to overcome them is ultimately what we mirror for them. So I allow my children to see me cry. I allow them to know when mommy is sick and has chemo, but I also allow them to see me go to Disneyland with them. The minute my doctor said that the metastasis in my spine was no longer gone or it wasn't there anymore and my bone scans were good. I had no signs of osteoporosis. You bet I went on that roller coaster. So there are things that I'm doing more intentionally because I know my children are watching me. And ultimately, that will become the foundation of their character. So that's what I want to leave behind with them.
And I will say, I'm sure your kids, they'll grow up to be as resilient as you. And I think that's what's really interesting is that resilience does not mean the absence of weakness, right? It means that it's the capacity to embrace that and show it to your children as well. So Annie, how has MBC really shaped your young adult life? You were especially so young. How did you find yourself coping with this really scary illness at such a young age?
Yeah, a lot of therapy, a lot of different types of therapy. Like if you I was 26 when I was diagnosed and I didn't have a family history. It took me 9 months to get a diagnosis because even though I felt like I was actively trying to get diagnosed, insurance tells me you have no family history. You don't need an ultrasound. And I had no idea then that a doctor could be wrong. Like, I really hadn't experienced that in my life. Every time I'd gone to the doctor, they tell you what to do, what to take, and you get better. So why would I question what a doctor's telling me? So I think for me, when I first got diagnosed, it was almost like I had a job. And so I knew I needed to do my job. Like, I need to go to the appointments, I need to keep track of them. Like, my mom flew up right away and she's trying to do that, but she is more aware as an adult and is crying more than her kid. And it's so different. And I felt like I was just in shock for a long time and that it didn't really end until they told me, okay, like, you're no evidence of disease. Like, we got it all out. Like, good job. You can go. Like, aren't you excited? And I was shocked by how not excited I was, by how I was like, no, 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 we're not done. Like, what are you, what are you talking about? And of course, little did I know we were very much not done because you are still hanging out with them a whole lot. But for me, it felt like so my first name is Dorothy, and my middle name is Anne. I've always gone by Annie. Don't steal my identity and my social security number. No, but I used to always say Dorothy has cancer, like Annie's fine. And so I almost like disassociated myself in a way from both. And then that worked for a while until it came crashing into each other. And I realized that I needed to figure out who I was now, because I always thought that cancer was going to be a phase, that it was going to be something I get through and then I go back to normal and I go back. And people hate this term, the new normal, because there's nothing normal about any of it. And it was so difficult for me to try to move forward with the person I was because I just was so confused by her. It was, in a way, I was so much who I was before I was diagnosed, but then, and then so many other ways, I was completely just a different person with a different awareness and a different acceptance of death and of mortality. And I feel like when you watch a movie and somebody is given like a week to live and then they make it past that week and they're still alive, you think there's this freedom to it. And it's just has not been my experience, even with hitting 10 years. Like I said, I thought I was going to drop dead that whole day. Like, and so I think what it's really done for me is force me to have an existential crisis really early, like midlife crisis really early, and to, in a way, become a very stubborn person because I just have trouble accepting petty things. I have trouble accepting not do it like wasting my time drives me crazy, like gives me such anxiety if I feel like I'm wasting my time. And I'm also, my parents are super young at heart, but they're both always reminding me that I can't just hang out with their friends. But for me, like, there's such a representation to me with hanging out with people in their 60s and 70s because they lose friends all the time. There's just this relatability there. And even with trying to hang out with people my own age, being in a space where I feel like no one else here has cancer, but we're all the same age and we still should feel like peers. I immediately feel like the little alien again of like, am I going to bring this up right now? Like, I don't want to bum everybody out, but it's not a bummer to me. Like, I'm not going to spend my life dampening like the strength and all of the things that I went through and that I've learned and that I've like this life that I fought for. I'm not going to put it in a package that seems pretty to make everybody else comfortable. And I think for a long time I did do that, even in treatment. And now I just am so grateful to be alive. And I know it sounds so commercial, but like I used to never cry. I cry at everything now. Like a butterfly flies by, I'm like, that butterfly. Like I'm just like a good meal, like really nothing taught me how to appreciate my life more than thinking I wasn't going to live, more than dying. To think when I was 26, I was begging, I was praying and hoping that I would make it to 30. And now that I'm 36, I'm like, God, I hope I make it to 40. And like, for example, I love my wrinkles, like that I have wrinkles coming up and gray hair is like, I get excited about it because there was a time in my life where I dressed up as an old person for Halloween because I was like, well, you're supposed to dress as like your hero, right? And it would be like, my hero would be me as an old person because it means I got to live. And so I just have a different outlook on life. And that's why it's so great when I'm with my fellow metastatic baddies because we really just understand that about each other. And I don't think that it's something that my peers understand. And I think also being so young and diagnosed, everyone expects that all of my trauma is around my fertility. And it's not. For me, I grew up in a big family. Of course, it was stressful and heartbreaking. But at the time, I hadn't really thought about having kids very much before I was 26. I just was very like, I'm going to be a sitcom star. And that's all I care about. Like, I'm a famous comedian. And I feel like when people talk to me, they're always trying to put that into this little delicate thing again to make it look like, oh, and you lost your fertility and this and that. And I'm like, yes, I had my ovaries removed. I froze my eggs. I did all this stuff. I'm like, but I'm alive. And really, I think that everything always comes down to, but I'm here. And today I'm here. And so I will do my best today. I will take the adventure I want to live. My motto has really been like, to live is an awfully big adventure, like the Peter Pan thing, even though the quote might ironically be to die will be an awfully big adventure. And I think it's so interesting that like I think about that quote so often. That is the debate with that quote, because I'm like, have I been actively alive finally for the last 10 years of my life? Like, finally present, finally appreciative, finally like myself, really learn to accept myself? Or have I been that aware because I've been dying? And it's like, it's all part of the same thing. And I think having had to accept that I will die at such a young age has made me live better than I ever would have if I hadn't had that. Would I like to have some estrogen back? Absolutely. But again, I'm alive.
Yeah. I think you're talking about this strange duality, right, of being a cancer patient. It's this horrible thing, but it's also in some ways can be one of the best things. It's like somehow it shapes you into a person that like the best part of you, right? It somehow brings out the best in you even as you cope with just this it's threat to your life. So that's such an interesting way that you've put it is like living with these two things, but you do it and you just keep living your life every single day, but it's made the best part of your it's somehow brought out some of the best parts of your life as well. Dr. Carey, I want to get back to the research and what we're doing here to help patients like Christina and Annie and let them live many more decades. So, what are we? You're also leading one of the largest clinical trials in the U.S., the ARPA, supported in partnership between BCRF and ARPA-H, which is again a federal agency. Can you tell us a little bit about that clinical trial?
Sure. So yeah, I mean, ARPA-H is a longstanding public-private partnership, and they take on new kind of concepts. And about a year and a half ago, they decided that the thing they wanted to take on was leveraging biomarkers. So I mean, we've been talking about the drugs that have helped people live better and longer. They're almost all targeted drugs of one fashion or the other. And so, we shouldn't lose track of the fact that this isn't by accident, right? These are, you understand the biology, you can develop something that targets the relevant biology for that particular cancer. And what this agency decided to do, and this is the agency that created like stealth technology and stuff. They're not a cancer thing, they're not even a health thing, but this right now, they did some of the pandemic work, and now they're doing cancer and other chronic diseases. And they picked cancer, metastatic cancer, as a place where they thought that they could accelerate advances. So, people working in this arena, plus this arena, plus this arena, they wanted to say, okay, design a trial that looks at a lot of biomarkers that have relevant drugs coming out, and design one big, we'll call it an umbrella trial. So, that tests a bunch of things and do it with several hundred patients and try and get an answer quickly for essentially biology driven treatment decisions that are being tested, newer ideas, and helping to identify resistance patterns and maybe the next step, et cetera. As you said, sort of what are you going to do for these patients serially? Because if the cancer figures out how to escape this approach, how did they do it? And does that leave you the opening for a new drug? So that's what this, our trial is called Evolve. It's breast cancer. There are 3 trials going on around the country. One's in colon cancer, one's in lung cancer, one's in breast cancer. And we're running the breast cancer one. There's 6 of us who are the principal investigators, and it's being run at 15 institutions around the country. That are already part of a BCRF supported consortium called the Translational Breast Cancer Research Consortium. So, BCRF has been in this game for a long time. So with support from ARPA-H and BCRF kind of giving us additional kind of innovations money, we've designed a trial that's going to do exactly that. So it should kick off in early 2026, and it'll enroll 700 women and men with metastatic breast cancer into essentially targeted therapy trials that we're in the process of designing, and we will have a series of them over the 6 years of the grant. So, and fingers crossed, it will give us great insight both into the biology and treatment resistance patterns, like why did something not work, which gives you an idea of what you should do instead. And I think it's going to be transformative.
Mhm. Well, I think what I want to dive into a little bit here as well is this concept of biomarker driven innovation. So we're talking about really, and if I'm understanding correctly, I'm trying to translate, is that you're talking about really individualized treatments. So what one person's cancer is telling you is driving their specific cancer, and then customizing the treatment for that specific marker that that patient has. Is that right?
That's kind of right. It's probably not going to be customizable, like with each one person getting a different treatment, but it is going to be customizable in the sense that we will identify individuals who have particular biology, that we also have drugs emerging that could target that biology. And so it'll be increasingly small groups of people, but because that is how you get to precision medicine.
Right, right. So there are some questions that we're getting. So I'm gonna turn to Q&A in a few minutes, just letting everyone know. I do want to close on a couple of things. So number one, Annie and Christina, I was going to ask you, sort of this question about how do you balance hope with uncertainty, and I think you guys have answered that really well. But I do want to ask again in case there's anything you haven't said already. But another question I wanted to ask both of you, and we'll start with you, Christina, is also how metastatic breast cancer patients and how you feel in relation to the larger breast cancer community, right? And so the way that MBC patients also relate to early stage patients, and how you sort of manage and toe that line, if you will. Because Annie, you've talked about it a lot, finding community within other metastatic breast cancer patients, but also how do you find community within the larger breast cancer patient community, and is that different? Is it different in the way that you relate to early stage patients? So Christina, why don't I start with you?
That's a really good question because, similar to Annie, when I was first diagnosed, I wanted to find community. And unfortunately, the resources that were available for me in terms of support groups for women who were nearly twice my age, and just where I was in my life, that chapter in my life just didn't coincide with where they were. And so it was really difficult for me to establish a community within that group. And then when I finally found it, I found that the metastatic group was sometimes tucked off to the side. And I understand that we represent a group of breast cancer patients that's really scary. And in fact, the first major conference I went to, they designated different stages by the lanyards of our necklaces, the color of our lanyards. And I remember hesitating, putting on this bright yellow lanyard. But what I realized was, you know what, there is so much to be proud of in terms of being an MBC patient because I get to be the voice of what a lot of these women don't want to face. And it is really scary. And what I will say in terms of relating to other breast cancer patients from other stages is that we're still all in the same boat. Whether or not you are diagnosed at stage 0 or stage 4 or have had a recurrence, we're all fighting the same fight. And so to try and divide all of us into saying, well, stage 1, 2, and 3, it's not as scary because I get to close this chapter. Sometimes I think there is some harm in doing that because at the end of the day, trauma is trauma, and that's what we have all experienced. But what I think is especially important for MBC is that we are leading the way in terms of what long-term care looks like. So moving forward, my hope is that when I go to these conferences, when I go to these retreats, I can hold my head up high as an MBC patient and And it does feel really good to say that I've celebrated 7.5 years and am doing really well because I get to see my pink sisters look up to me and know that regardless of what stage they're at, even if they do have a recurrence, there's still a lot of hope for them in the future also.
And Annie?
I thought of a really good analogy. Well, because I was like, yes, yes, yes. So this is the way that, and I was de novo metastatic. Like I've never been in early stage for like 2 weeks. I thought maybe that's if, because I have bony islands in my pelvis, and they were like, you have bone mets. Just kidding, you don't. So the thing in your liver is probably not that too. So there was like 2 weeks where I thought maybe I'm stage two. And that's it. Otherwise, I've always been stage four de novo from the start. And again, I had so much trouble finding anyone who wasn't twice my age. But as I've gotten more into the community, especially like I go to a lot of events and speak at them, and I see this divide. Like it does feel, and it feels like to me in this analogy that the early stage survivors, and I mean to offend no one when I say this, just my perspective, it's like they're on a party yacht, right? Like we're all out on the ocean and they're on this big, beautiful pink yacht and there's champagne and they're having a great time. And then somebody gets thrown overboard and you're flailing in the water. And guess who reaches out a hand on this safe, beautiful boat that maybe on the outside looked like a scary pirate ship. And then you get on it and you realize, oh, we're just like sitting around making tea and talking and laughing and like, it's so safe and warm and you're so welcome here, and it's okay that you didn't know that it was safe and warm and that you were welcome. It's okay that you thought it was scary. There is It's so interesting to see the celebratory vibe be diminished when you enter a room because you're the metastatic person or because you represent somebody's worst fears. And I don't hold anybody, I don't think it's wrong to feel that way. I can put myself in their shoes and try to understand that. The only time it really frustrates me and is when I watch people shut down about it because they're afraid to hear it. And it's like when you say, how do you balance hope with uncertainty? Acceptance. You have to accept the reality. And the reality is, no one who is stage four asked to be. It doesn't mean we didn't have early detection. There's plenty of people, the recurrence rate is 30%. It's even seemingly going up. And usually, when you have a recurrence, it is more often than not going to be metastatic. There are so many of us who are diagnosed young de novo, not because we did something wrong and not because you're doing something right. And so I think this misrepresentation of like why we're at the stage we are, and instead of it being they just are there and we need to all look out for and support each other, it does feel like there's a sense of blame. It does feel like they expect us to have a sense of ownership for that. And that's not fair, I think. And it's not, and I also think a lot of times it's not intentional from the other community, but there is something of like, you're representing our worst fear. So we're going to shut down when we talk to you and keep doing what we're doing because we think that it's going to keep us safe, when in reality, the way to keep all our entire breast cancer community safe from previvors to metastatic is to all make it so that it is not a terminal disease anymore. And that comes, as we were saying, from stage four research, from making sure we don't run out of options, from keeping us on these options longer so that we don't develop resistance to it. And if you're so in a little Glinda the Good Witch bubble on your party yacht that you can't look out and see who you're letting drown, that's cruel. And we have to look out for each other and we have to not be afraid to hear the stories because like I said, there's nobody funnier than the metastatic community. There's so much misrepresentation about what we're like because it seems so doom and gloom. And I would just encourage anybody to just listen with an open heart and to just really listen when we tell you our stories because we've had to fight through so much and we're fighting for every stage every single day, and we'll keep doing that forever, hopefully for a very long time for all of us.
Well, thank you. I think those are both really insightful because it just it kind of just reminds us, especially for those in the early stage community, is being just mindful, right? It's just being aware of the way that you're talking about the disease. I will say that at BCRF, one of the things that I think is so empowering, especially in my job as well, is that I know what we're doing here at BCRF. And that's also what gives me hope, and why, even when I fear exactly what you said, it is really scary to imagine becoming a stage 4 patient. But I will say, meeting women like you and Christina offer me so much solace to know, like, actually, I know women who are thriving with this disease. So no matter what happens, there's so much still room for hope. And my inside view at BCRF, we're funding this year $25 million across 96 projects. So we are really, like, one of our biggest goals here, and that's about 30% of our entire grant portfolio. We are going to drive change. We are doing that right now, and I've seen it happen in the past decade here, at my time at BCRF. So I do want to now, having said that, talk to you, Dr. Carey, really quickly, about what your hope is as someone who's in it, as someone who's doing this research right now. What do you envision the next 5 to 10 years to look like, especially in the MBC space?
Well, first off, I just want to say, like, the stories that Christina and Annie told, like, this is where the early setting patients should have more exposure, because I do think there's so much lack of knowledge and fear. And you guys are incredible ambassadors, and but there's a lot of people like you, like, maybe not quite as funny, but really amazing human beings doing incredible things. Like, listen, a third of my every clinic day that I'm in clinic is metastatic patients, and they're wonderful. And I do think that you can eliminate the fear and the sort of otherness by having these stories be readily accessible, and to do that. So you guys are amazing. Listen, what I described in the very beginning as the trajectory since I came out of training, this remarkable change that has happened in longevity with metastatic breast cancer, there's no reason that's going to not continue, right? I mean, there's so many drugs that are coming out. ESMO, which is the European Medical Oncology meeting, starts in a few days. I already know there's a bunch of things that are going to be reported there that we will all be digesting next week. And the same at San Antonio and ASCO. I mean, these are things that build on each other. And so my anticipation is that we will continue to see attention to longevity, but longevity with quality, and with novel. There's a whole bunch of novel approaches, kind of approaches that never existed before, a year or two ago, that people are now developing. And so, number one, I think that's low-hanging fruit. That's absolutely going to happen. Number two, I think, Sadia, you mentioned in the beginning how encouraged you were to hear someone say, listen, I think occasionally we do cure a metastatic breast cancer patient. And I've been at this for a while, and I also have these patients. The problem is, I don't know what happened. Like, I don't know why. I've treated thousands of people, and I have a handful of these patients, as does Ian, as does, lots of other people. Any of us who have been doing this for a while has those stories, but anecdotes aren't enough. We have to get to saying, this is how we did it. This is how we cure that person. And I think there are some of these really new drugs that are out there. The only way we do this is by better drugs. And if mortality from breast cancer has dropped by nearly half in the last 20 years, it's like 43% was the last number. Like, most of that is from better drugs. Like, those better drugs, I think, Annie, you mentioned it first, they start in metastatic breast cancer patients, and us showing that an approach is useful and safe. And, we're going to be doing this. So it's entirely possible that we're actually going to be able to take a run at a cure kind of approach for metastatic disease. That's what I would hope for. And I would say it's not out of a few years ago, I'd have said that's kind of nice, it's aspirational, but it's unlikely. I'm a lot more optimistic with the nature of the changes I've seen in the last few years, that's actually something that we could make a run at.
Well, first of all, yes, that's right. That's right, Annie. Well, first of all, thank you all for being here, and I want to now switch to Q&A. We've gotten some really great questions. I'm going to try first. Number one, I should add that we don't answer any personal medical questions, so we will sort of speak more broadly to some of the questions that we've gotten here. So there's a question here about how about lifestyle? How do lifestyle changes impact specifically a metastatic breast cancer patient's prognosis? Dr. Carey, any insight there?
A couple of insights. The first is that, people who are healthy tolerate the things that we do to them better than the people who are unhealthy. And so, there's, a reason to try and be a healthy person, simply for that reason. I'm just going to take a page from Annie's book a little bit, because what I usually tell my patients is, listen, you didn't do this to yourself, and there's a real limit to what you personally can do to control this cancer. You didn't give it to yourself. It's not because of something you ate or didn't eat or did or didn't do. This is a real thing. Now, the extent to which you can partner with your caregiving team and be effective in getting the drugs that are, that are available to you, that's going to help. But, you know, I always, I get, frankly, if you don't mind my saying, I get a little angry with people who come in and say, listen, I was reading on the internet that it's my fault that I got this cancer because I ate processed sugar or, didn't have a gluten-free diet or whatever, which is just, there's no data to support that statement. And that's why I always say, listen, you didn't get your cancer because you had birthday cake with your kid, and your cancer is going to grow because you have birthday cake with your kid. That's just an old wives' tale, and you shouldn't spend any time on it. So, like, realistically, try to be healthy, but this is not on you.
Mhm. Thank you. There's another question here specifically about brain mets. We know that brain mets also has been traditionally tricky to treat, but there are new drugs on the market. When Dr. Nancy Lim, who's a BCRF funded investigator, had a major trial about. Do you have any insights, Dr. Carey, on just treating how far we've come in terms of treating brain
Yeah,
mets?
sure. It turns out I take care of them too. So brain mets is an interesting arena. It's one of the few places where we know that locally directed therapies, either surgery or radiation, actually can help outcomes. Now, there's some practical reasons for that. It doesn't look like locally directed therapies work for the liver, for example, or for the lungs or whatever, but the brain it does. And we do less and less surgery, which is probably a good thing. We do much better radiation than we did before, and we can treat lots of metastases with targeted radiation. And those are techniques that kind of have evolved, over the last few years and are really quite effective. But as you can imagine, I think, again, the name of the game is going to be drugs. And so quite a few of our newer targeted drugs actually cross into the brain quite well and can handle brain mets as well as they handle anything not in the brain. And that's where, we actually sometimes don't even do the radiation. We'll go first to the medical therapy, and our radiation docs are happy with that, because the drugs are increasingly effective in the brain.
There is another question here also about the trials that you mentioned, the new trials that you'll be launching in early 2026. Is there anything patients should be looking out for? Can they access them? How can MBC patients be informed about that?
So the trials will all be running through sites that are part of the Translational Breast Cancer Research Consortium, which is academic institutions around the country. Most of them are referral kind of places that many of people who are on this webinar will have heard of. But you can also just look it up. So 15 of those institutions scattered again around the country are all going to be participating in the trials when they open. So you can look up TBCRC. TBCRC, I think, is a link on the BCRF site, because BCRF was one of the founding supporters of TBCRC and remains a key supporter for, even separate from this trial, just TBCRC in general.
Right. So one final question was specifically around lobular breast cancer patients. Are there different treatment protocols if you've had lobular?
So not yet. I mean, there are some genetic reasons, like at the level of the tumor, not at the level of what you inherit, but there are some genetic differences in lobular that make it not make balls, but make kind of fronds. When it comes to treatment and drug therapy, there were some thoughts that there might be differences in behavior in lobulars versus non-lobulars. It doesn't look like that's panned out particularly well. And for the most part, the general approaches that we take from a medical standpoint are similar for lobular as for ductal or mixed.
Gotcha. Thank you. And there's one final question here that I'll answer very quickly is um, someone asked not using the word cure. Why is that? I will say that at least at BCRF, that's our ultimate goal. Our ultimate goal is to end the disease and make sure that people are able to sort of not have cancer in their bodies, right? That's the ultimate goal. One of the things I'll say is that it's a multiplicity of cures, right? Because breast cancer is a multiplicity of diseases, it's not a simple cure. But what Dr. Carey was talking about earlier is that in the current state of affairs, it's sort of a phase, right? It'll take some time to get to cure, but in the meantime, we can make sure that patients are living long with this disease, even if it's as a chronic disease. So I just wanted to clarify that question as well. In the meantime, first of all, thank you, Annie. Thank you, Dr. Carey. You guys have provided such incredible insight. So I'm so appreciative of your time, your stories, and your commitment to this research. So we are at a critical frontier where targeted investment can really drive transformative change, as we've seen over the past 3 decades. Now, I'd like to welcome BCRF's Chief Scientific Officer, Dr. Dorea El-Ashry, to share just a little bit more on BCRF's commitment.
Thank you, Sadia, and thank you, Christina, Anna, and Lisa, for all of the great information you gave everybody today. As a scientist running my own lab before my role here at BCRF, I studied metastatic breast cancer for over 30 years. And just as when I started, it remains a key priority for all of us, the patients, the investigators, and for BCRF. 30 years ago, my aunt was diagnosed with metastatic breast cancer at age 37 and died just 2 years later. We have made such tremendous progress, as you have heard here today, and so reason for real hope. But we are keenly aware of how urgently we need to drive progress to not only live longer, but also live well, as we've been talking about. In 2013, BCRF launched the largest global effort to study metastatic disease, known as the Aurora Projects, in the US and Europe, supported by the Evelyn Lauder Founders Fund for Metastatic Research, and Dr. Carey is one of the principal investigators on that. These studies were groundbreaking in sheer scale and developed the largest tissue database of metastatic breast cancer patients in the world that is now in the BCRF Global Data Hub and will provide information and data to continue studies on metastatic breast cancer. But they also discovered key molecular changes unique to metastases. As you heard from Lisa, understanding the biology of how metastasis works is what will bring us forward. And one of these results that came out of the Aurora US team and then was validated by the Aurora EU team was that metastatic cells can switch subtypes. So in other words, evolve to find new ways to survive that may explain one way that metastatic and metastases resist therapy. And then in addition to Dr. Carey and across all of our grant programs, I wanted to tell you all that this year we're also supporting a number of early career scientists tackling metastatic breast cancer in innovative ways. For example, in the biology of metastasis in triple negative disease, exploring better prediction of response in hormone receptor positive metastatic disease. And more are investigating the tumor microenvironment and the tumor microimmune environment, as well as treatment resistance and health disparities. So again, thank you all for joining us for this webinar. I hope you know that our commitment is unwavering.
Thank you. Thank you, Dr. El-Ashry. Yes, we've been at this for a really long time, and we are going to keep doing this until nobody dies from this disease. So thank you all for joining. We do have other webinars and events coming up. Please visit bcrf.org/events to stay in tune, and please sign up for our mailing list so you can know when we've got new conversations coming up. So we will be sharing this online as well. There will be a recording. And again, once again, just thank you. Thank you all for being here with us and supporting our cause.